Good afternoon, everybody. Looks like we've got a dozen panelists. Let's just make sure we have a quorum. So Tino, Chief Nieto, Scott.
We have a quorum.
Olivia.
Okay, let's go ahead and get started. It's a little bit difficult to be number 3 in the lineup, but I appreciate your attendance, and we will start off with a call to order at 1:03. Welcome, everyone, to this month's EMS operations meeting. We'll start off with opportunity for public comment. Any member of the public may address the committee for a period not to exceed 3 minutes on any issue not on the committee's agenda. The committee will listen to all communications, but may not take any action. Are there any members of the public who wish to make a comment?
Hi, this is Reb Close, and many of you guys have heard my public comment so far, but if I may just briefly address the EMS Operations Subcommittee. I'm an emergency physician at CHOMP and then one of the lead clinical physicians for our county's Prescribe Safe initiative. I just wanted to bring up today something that we've talked about actually several times through the day, and that's just the tremendous increase in fatal and non-fatal overdoses in Monterey County. And then obviously we're dealing with this on a national level. But that said, we've been brainstorming, Teresa and Kimberly and I, about different things that can be done as a team effort to help our community in response to what we see as an oncoming mental health and substance use just tidal wave coming towards our community. And one of those is ODMAP. And that's something I brought to MAC and EMCC earlier last year. And that's basically a mapping program so we can figure out what's actually happening in our community and then determine the responses that we have. And in order to do that, there's a number of different ways that it can be done. Automated integration with the PCRs is ideal because that's the least labor intensive, but that's going to take a while to get that up and running. So in the meantime, we have some other options that I'd very much like to pursue, and I'm hoping we can bring that up in a future meeting as an option that we want to participate in so we can share data about what's happening in the community and formulate our response. And the second thing I wanted to quickly bring up was one of the potential responses, and our EMS agency has written policies and protocols for leave behind naloxone, and the naloxone is free of charge from grant funding, and so we can help every agency get that. And what we're hoping is there's almost leave behind kits that will have substance use tip cards, sheets on where to get services. We even have some of them that have CPR face shields, and you can put all this information, hand it to patients, family members, victims that choose not to be transported and are left in the care of family, basically so you can arm the community with a way to save a life and also with services when the patient may be ready. So I thank you, many of you, for hearing me chat about this a couple of times today, but I would like to ask that we can put those two things as action items for future meetings so we can determine how we can best do this in our community. And neither service has a charge associated with it. ODMAPS is free and the naloxone is a free supply. So I would like to ask for that if I can. So thank you.
Thank you, Dr. Close. I do recall kind of right before COVID hit, we had a lot of momentum going for this initiative, and it's incredibly worthwhile, and look forward to picking up where we left off last year.
Thank you.
Comment, Estella? Jim? Chief Llewellyn?
Yes,
Jim has a comment.
yes, please, go ahead.
Oh, hi, Chief, it's Dr. Stubblefield. It's simple. I just wanted to just make sure everyone knew that I was attending the meeting, part of the audience, but as the medical director for controlled substances for many of the fire agencies, I just wanted to announce my presence there. That's all. Thank you.
Great. Thank you, Dr. Stubblefield. Glad to have you with us today. Any questions or comments for Dr. Close?
I just wanted to add that yes, Dr. Close approached us recently about being able to connect to the ESO's program so that there can be an extraction of data. She would like to see more real-time data related to overdoses. Currently, we are providing monthly data, aggregate numbers on the number of overdoses, but the need is different. We did let Dr. Close know that, not sure off the top of my head, don't quote me on this, that this might require an amendment to the current ESO agreements that we have with each of the agencies, or it could be some form of MOU or agreement between Prescribe Safe and each of the entities that participate in ESO. So we need to explore that a little more, and we're happy to do that with her. So one of the first, to get this moving along, we invited her to speak at these meetings today. And I also brought it up at the Monterey County Fire Chiefs Association, and there seems to be support. This is a great program in the community. We want to support it. We know that the agencies support it as well. And I know that sometimes once we start talking about amendment to contract or MOU or another contract, then things can get a little complicated when we're, juggling a number of different agencies. But we are committed to doing what we can.
Thank you, Director Rios. Any other comments before we move on? Okay. Item number 3, approval of past operations meeting minutes. And the issue before us is approval of the January 13th, 2021 Operations Subcommittee meeting minutes. Do I have a motion to approve the minutes as written?
Motion to approve.
I'll second that.
Okay, we have a motion from Scott, and I'm sorry, I didn't capture the second.
Olivia Madrigal.
Olivia. Okay. Just in terms of Zoom etiquette, I believe we do need to take a roll call vote to approve minutes. Is that correct?
Correct.
Okay. All those in favor say aye. Chief Nieto? I see her there. We'll come back to her. Scott?
Aye.
Jeff?
Aye.
Circling back, Chief Nieto? Dave Jednick?
Aye.
Olivia?
Aye.
Tino?
Aye.
Okay. Chief Nieto, are you able to approve minutes, or looks like your mute is still
Hi, I'm
on?
sorry. I had my other manual mute button on, so aye.
Okay, no problem. Thank you. Minutes are approved as written. Okay, moving on to item number 4, correspondence. It doesn't appear that we have any correspondence to review. So we'll segue straight into item 5, old business. And that starts with an update, COVID-19 response update from Jeff DeAndrea.
Yeah, good afternoon, everybody. Since our last committee meetings, most of my time and personally from the Mohawk perspective, I've been involved with the EMT and paramedic vaccination LOSOPs and authorizing fire personnel. It just occurred to me that I've been saying prior to committee meetings, 9 agencies, and I just authorized Fort Hunter Liggett paramedic program yesterday, final approval. So I got to acknowledge that, but it's 10 local fire departments, and we have 138 EMTs and paramedics from these districts that are authorized to administer vaccines right now. That's been the major advancement in terms of COVID that we're doing. I've been also sort of reminding folks that most of these, and some of you are here on the call, most of the fire agencies, with the exception, everybody with the exception of Monterey Fire, has opted not to become a vaccine provider. But the attributes of the Johnson & Johnson vaccine that are out now, which come in smaller minimum dose shipments and do not need any particular ultra low cold storage or anything like that, may cause some folks to reconsider. It's may become a lot easier to be a provider and get vaccine doses shipped directly to you. So that's the main COVID response of the past 2 months. The Mohawk program continues. We're still coordinating resource requests from PPE to staffing requests, and a variety of other things, safety products and whatnot. We've moved into the vaccine hardware situation, and we're coming up against some serious demand globally for needles, syringes, and sharps containers. So we're doing our best to get a hold of enough of those materials, especially sharps containers, which are becoming valuable. And then Chief Welling, I don't know if you were on the last committee. I want to thank you because you sent us a great update regarding the late January weather event, just giving us a heads up of the teams that you had put on ice through Cal OES Fire Branch. And that sort of motivated us to get also proactive and prepared. And with that event, we had some daily meetings with Bay Area, MOACs, the regional coordinators, and the EMS Authority. And we all sort of concluded this is a great way to prepare for weather events, to have these daily Bay Area calls to just check in and ensure readiness. And those are the highlights there of the last 2 months. Does anybody have any questions?
I have something. We just received a memo from the Emergency Medical Services Authority providing additional guidance for the training and administration of the vaccine by EMT. So I forwarded to you. Let's make sure that we follow up.
Just a few minutes ago. Yeah, so I'll distribute that, and hopefully it doesn't throw a kink in the works of anything we're doing. I haven't examined it yet, so we'll take a look. And anything else out there?
I've got a question, maybe more applicable for some of the hospital personnel and attendants. We get sort of a daily status report from Community Hospital, which shows current COVID admissions, total number of admissions, basically ongoing trends in terms of their of COVID impacting Community Hospital. I'm sure the other hospitals do the same thing. And I'm just wondering if providers have access to that, because I personally find that to be very valuable information.
Yeah, we receive the CHOMP daily as well. And do we have?
We'll look into the.
We'll look into that as well from the others. But
I actually have reached out to the other hospitals to see if they do anything like that. I have not yet heard back from them.
Okay, yeah, it's actually turned out to be a good planning tool for us in terms of, if you look at 6 weeks ago when we were in the midst of a real surge. CHOMP was in the 40s to 50s in terms of ICU bed commitments to COVID patients. And it really put our staff on alert that it's going to be either extremely tight getting a patient in, or we may be looking at transporting to a secondary facility. So just a good planning tool is what I found it to be.
Indeed. Okay, any other questions for me? Okay, thanks.
Thank you, Jeff. Moving on to item B, the RFP with Director Rios.
Thank you, Chief. The report is brief. The RFP for a new ambulance provider Monterey County exclusive operating area closed last Friday at 3. Unfortunately, the county did not receive any bids. We are at this time assessing our options. Our primary goal is to ensure continuity of services.
Very good. Any questions for Director Rios on the short-term future of ambulance operations in Monterey County? Okay, hearing none, we'll move on to item 6, new business, and Kimberly Hernandez with term expirations.
Ops membership, term expirations are coming up on the following subcommittee members. They're set to expire on June 30th of 2021. Captain Scott Houchin, Chief Eric Welling, Chief Tina Nieto, Cassie Caldera, Tina Ariano, and Dave Jednick. And the EMS agency will provide a report to the Ops Subcommittee on the Ops City Subcommittee appointments at the May 2021 Ops meeting. Any questions?
Okay, thank you, Kimberly.
Thank you.
And that brings us to EMS System Quality Improvement Plan with Deborah Hopgood.
Good afternoon, everybody. We've had a bit of a break for our EMS QI committee meetings over the past several months due to COVID, the fires, and several other situations. Within the last month, we've had the opportunity to start those committees up again. We've had meetings of all 4 committees, including CQI TAG, TQIC, STEMI, and Stroke. We use those meetings as a bit of a reset for our QI programs. We spent a lot of time internally just looking at our processes and what we've been doing, and some examples from other systems as well of how we might improve our processes. During our meetings with the 4 groups, we had a discussion related to different organizational capabilities related to our specialty care patients, the organization's QA and CQI philosophies, and then a kind of a general discussion of some ideas for performance indicators and performance improvement projects for the coming year and ongoing. We've made several steps so far to implement some changes that have come out of those committee meetings. One of the things we've done is sent out a SWOT analysis form, asking our stakeholders to take a look at the strengths, weaknesses, opportunities, and threats, challenges faced by the EMS system in Monterey County. Those are due back by March 31st. That's included in your agenda packet for the meeting as well. And thank you to everybody who's taken the time to submit those so far. We've also held a policy and protocol meeting for the CQI TAG group to give them a chance to review the policy changes that occurred before the MAC meeting that we had earlier today. We've resumed daily ReadyNet MCI drills as something that came out of our TQIC committee. And then we've been able to obtain access to Natividad's trauma patient data for patient follow-up. So we have an initial set of data that's come into us, and we're working on a process through our IT folks to update that automatically on a regular basis. So we'll have a good, hopefully, daily or regular updated performance information from them. Also this morning, we were able to take the first steps to getting access to the Get With The Guidelines data from SVMH for their CAD and stroke registries. So That should help with patient follow-up information as well for our field providers. And then kind of as a summary, we've had kind of three main trends of performance improvement type projects to come out of those meetings. One related to ESO and a variety of topics surrounding our PCR process, access, and then follow-up as well. Patient outcome data, and then issues related to MCIs as far as updating our plan, instituting drills, getting back to training related to MCIs, taking a look at current active harmer, active shooter policies, and then some triage tag days for the county as well. Any questions?
I just wanted to make a quick comment. I know that a report on CQI tag activities usually doesn't come to this committee, but QI is something that, you know, impacts the entire agency, or everything that we do should be approached from a QI perspective. And because we had not met, we thought it was a good idea to bring this report here today, just so that all of our committees and make sure that our stakeholders know that we are moving forward with the revamp of our QI committees and just the implementation of areas that can lead to system-wide improvements of the system. Of particular interest for this group, I thought in Deborah's report, was the whole standardization of the PCR. We understand that it is a project that has not been taken on from the beginning of ESO, and it is something that it is clear that we need to do, and we need to do sooner rather than later. So at the very least, we want to introduce the subject and then start to work towards standardizing the PCR so that we can get better data in, so that we can, you know, when we extract the data, we can do better analysis of that.
Thank you, Director Rios, and thank you, Deborah. I think those are fantastic objectives to focus in on: the patient outcome piece, the MCI and training piece, and then the standardization of data. I'm very excited that these issues are receiving some attention. This is kind of me personally speaking on my thoughts towards ESO, but the more I dig into it, there's a lot more to ESO than just data input. They're now doing things like hosting webinars. They host online trainings. So there's a lot of additional bandwidth that providers may not be aware of in terms of their ESO subscription. And circling back to the OD map and Naloxone Behind project that Dr. Close is initiating, I think if there's a way we could tie that into ESO, that would achieve some of our objectives of using more of its capabilities.
And that is exactly Dr. Close's ask for a direct connection to ESO, but you know, we're trying to see exactly what that means. We're exploring that with Dr. Close more closely. It is, from what we heard, other systems already do that, but we don't know. Not every system has a system like ours, where the EMS agency has an umbrella account, but each entity has its own account with ESO. So yes, we wanna see how others are doing it. If it's the same situation, it would help us to see how that is done. As I mentioned earlier, once we get, if there's a need to amend the agreement or execute some form of MOU, we know that is where things can get tied up, you know, because every entity's council is gonna be looking at that. So coming together, expediting something, I think is gonna be an issue that we will get there. I think that we will. It just might take a little bit of time.
Okay, that sounds good. Any further questions for Deborah before we move on? Next item under new business is letter C, EMS aircraft request matrix update with Steve Brooks.
Good afternoon. Due to changes in deployment between CalStar and Mercy Air, there have been aircraft added locally, CalStar 14 in Watsonville and Mercy 34 in Paso Robles. These aircraft were not reflected in the previous matrix for response to scene calls in Monterey County. So we've updated the matrices both for the North Zone and the South Zone to reflect the addition of these two aircraft. In addition to adding the aircraft, a couple other minor changes. One of them is that the aircraft in Paso Robles, so it's a little further away by distance than the Mercy 20 at Hunter Liggett. Because the approval process with Fort Hunter Liggett to allow the aircraft to fly off base does add time. Mercy Air, and with our agreement, believes that Mercy 34 would be a more prompt resource for the south end of the county. So you'll see that Mercy 34 has priority. And can we go up to the South Zone, please? So even within the South Zone, we have Mercy 34 as the primary aircraft. A couple other changes. Because of the primary aircraft is in Paso Robles, and then it's still in Salinas with CalStar, the dividing line essentially for where to divide the county in the North and the South Zone was moved south just a little bit from south of King City to Highway 198 at 101, and 198 at 101 would be remain considered South Zone. So that change was made. Also, we've determined that some of these aircraft on our list, and we've used a significant number of aircraft on incidents within Monterey County, just cannot make it to the county in time to be useful for scene calls unless there's extenuating circumstances. For example, if there's prolonged extrication and a really large number of patients, as you see in the South Zone, Skylife from Fresno Visalia, it's not likely to be able to get here in a timely manner. So we've put a line in there and really, do not intend to have call or helicopters below the dark line called for scene calls unless there's, again, an extenuating circumstance. These helicopters can certainly be used and brought in as, for secondary transport. We saw the need for that after the bus crash in Soledad, where we distributed patients, critical patients, to our local hospitals that were not trauma centers. And to get the patients out, we requested additional EMS aircraft, and these helicopters can definitely be used for that. We also have included some notes for safety of aircraft response. If there's two EMS aircraft that refuse the mission due to weather, at the scene or other flight conditions, we don't want to continue shopping for aircraft if we find someone who's willing to take the risk with the weather. But of course, if it's weather at the site, for example, Salinas is socked in with fog and Wattsville socked in with fog, doesn't mean that we can't request Mercy Air out of Hunter Liggett or out of Paso Robles, who may have clear weather at their base. So those are the main changes with the matrices and the reason why we've made the change. Any questions?
Hey, Steve, this is Scott. Do we have any numbers for total aircraft deployments over periods of time? We used to get that information. I'm not sure where we're at these days.
Daughter and breastfeeding.
That's a very good question. We've not looked at those numbers in quite a while. That's pretty much why you haven't received
I'm
them.
sympathetic to what you're saying.
We do get a monthly report from CalStar. We don't get anything like that from Mercy Air.
The kids are in ballet or
Dr. Stubblefield, yeah, there we go. All right, and any other questions? Thank you very much.
Thank you, Steve. And if we want to return back to the agenda, please. Next item is really more of, it's intended as more of a group than a presentation. And it involves the Natividad's DMIST EMS to trauma team handoff project that was initiated probably 2 months ago. What I'm interested in is to hear from field providers, whether it's being used, whether it's the transition has any benefits from what we used to do, and just to see how that program is going.
Yeah, I'll jump into that one a little bit. Yeah, with the DMIS process, it moved, pretty quickly at a time when we were transitioning to COVID pandemic, as well as policy updates, and it moved in a matter of days and a couple of weeks. It doesn't seem like it's too much of an option, though, when you walk into the ED and a card is handed to every transport provider to follow a script. It's been, canned as an optional practice, although it doesn't seem to be that optional at this point. I think it's created some challenges. I totally commend the process to improve communications and setting the timeout so there's a period of communication that can be clearly transferred. However, the process has created some significant internal challenges with what truly is the policy for the EMS agency, what's the policy for the hospital, and what is truly the most appropriate way to hand off a trauma patient.
Okay, thank you, Scott. I'm not sure who is most involved with this this change at the EMS agency. Jeff, would that be you or Steve?
I can speak to it, Eric. We met with Scott Wayland, who is the nurse practitioner who was behind this. We had a long talk with him, and it was described to us as, and it does appear to be, this is kind of like the SBAR reporting that has been in our policies for a little over a year, but it just focuses the report a little bit more on trauma by having the laminated card that should help guide you through the report. It is voluntary, and I understand that you're being voluntold when you're being handed a card. If you choose not to do that, there should be no repercussions. If there are, please report it to us or to Cassie. And in the meantime, the biggest part of it that we saw, I believe, is that there is a moment of silence where the paramedic gives the report one time and everybody who needs to be there hears it. And if anyone should be there and is not, then they'll have to pick it up secondhand from someone else. But it honestly was about collaboration. It was just the implementation of the process kind of left the EMS agency out. And I think that probably created some confusion in the field.
Yes. Thank you for the explanation, Laura. I agree with everything you said. This is a great concept, and I think it just caught some of the transport providers, specifically the ones that aren't going to Natividad on a daily basis like AMR, a little bit flat-footed. And in communication with our paramedics, I made it clear that it was voluntary, and some chose to continue with their time-tested trauma handoff at Natividad, and all our ambulances have the laminated card inside of the ambulance so they can grab it and refer to it if they want to. But I agree with you. I think the implementation was a little bit fractured, I guess.
And I'm hoping that the memo that the EMS agency sent out clarified that, yes, we do support this. This is, but also that it is voluntary.
Yeah, okay. Dave, any feedback from your folks on
No,
Intimidate?
I don't think we've had one transport since the implementation, so none so far.
Okay. Good. Thank you, everybody, for your feedback. Any further comments or discussion on DMIST? Okay, let's move on to item E, which is in a similar vein. I want to plant the seed with, I probably should have started with MAC, but I wanted to plant the seed with EMS Operations Subcommittee to discuss the possibility of bringing ketamine into our system. And in a way, this circles back to those additional educational pieces that ESO offers. ESO put on a webinar about 2 weeks ago. They had a panel of physicians across the country, and so the webinar was ketamine in the pre-hospital environment. And what I came away with a 90-minute presentation was, this is a safe drug. It's been around for a long time. I think ketamine was synthesized in the 1960s. And it is being used with increasing frequency in EMS systems across the country with very few negative side effects. So what I'd like to do is start off with just a conversation and maybe an audit of interest. And if this is something we'd like to move forward with, we can take it back to MAC and I'll deliver a more formal presentation.
Hey, Eric, good questions or good process here. As I understand it, it's approved for local optional scope of practice as Mountain Valley, Inland Counties, and Riverside have completed a pretty exhaustive trial study of ketamine use, and it appears that it is really safe. Probably the only negative is coming out of Minnesota, which law enforcement's allowed to administer ketamine, which may not be a great decision at this point. But it appears that all the information and the policies, procedures, and authorities are there. And I think it's a really good step. You know, it follows pretty closely with Dr. Reb Close's overdose program too. As we start to, I don't want to say, you know, not have access for desirable chemicals for people who are seeking when there are other options out there that work very effectively and don't feed into the opium pandemic too, or epidemic.
Absolutely. Well said, Scott. And yes, that is another ancillary benefit to ketamine is it provides us another non-opioid option for pain management. That's one of the primary drivers in the systems that are using it.
So Eric, I have used ketamine, actually not on myself, but on patients way in the past. But we used it just to kind of sedate small kids to suture their faces or something. I am not overly familiar with ketamine as a painkiller, and I know it's kind of a hot topic lately. What is the benefit of ketamine to fentanyl and morphine, other than the fact I understand and totally get the non-narcotic side of it?
Just in a nutshell, Laura, yes, you cited probably the first benefit, which is that it's not an opioid. It also has very minimal physiologic effects. So some of the effects on blood pressure that you would experience with morphine, the routes of administration, you can deliver it on an intranasal route, which is beneficial for pediatric pain management. And it also has a reasonably short onset time that it can be used even for fairly short transports. So I think given the different types of environments that we have, pre-hospital environments with urban, suburban, and rural, I think there's broad potential for usage to meet the various needs.
Thanks, Eric. And
Does anyone else?
Sorry, I was just going to comment from my perspective, as you had mentioned, you know, there and Scott as well. There is some precedent here, and within California, there's several jurisdictions that are using ketamine. I did speak with the medical directors of Inland County. And also San Luis Obispo had initiated the process, although they did so right before COVID hit and had stepped away from it during the course of the pandemic, but had an intention to revisit that. And certainly from the perspective of the medical directors that I spoke with, there was a very positive experience with the use of ketamine within their EMS jurisdictions. I, you know, just from my own clinical experience, I really like the drug as far as you know, being able to serve as a dissociative agent and maintain hemodynamics in patients that may otherwise be a little tenuous. And so I can certainly see the benefit from a clinical standpoint, and I'm interested in exploring it further for use in this county. One question I would have to just put to the stakeholders is as far as cost, and I know that one of the other topics that you were interested in discussing was taking a look at whether minimum stock is required to stock both morphine and fentanyl, or whether you know, there can be an adjustment to minimum stock requirements so that particularly first responding fire paramedic units would be able to stock one or the other in the interest of you know, expense and other things. And so, you know, do the stakeholders feel comfortable, if we were to move in this direction, would the stakeholders feel comfortable absorbing the extra cost of adding another agent to our arsenal?
Yes. And I don't know anything about the cost or the storage requirements. Dr. Burley, do you know offhand, is this an affordable medication, or is this more towards the, you know, the glucagon price scale?
I haven't looked into pricing. I think we're early in this. We just had, you know, received some communication, I guess, last week from you regarding this. So we haven't had a chance to really look into pricing and what's available and what kind of deals can be ascertained for EMS agencies and fire agencies. So I don't have that information at the moment, but it's just, you know, just a consideration. I love the idea, but I want to make sure that you know, our enthusiasm for the medication also takes into account practicality of carrying it, storing it, and you know, I know that all of the agencies are under some, you know, financial constraints as well, so I want to be respectful to that.
Hey, Eric.
Yeah, go ahead, Jeff.
Yeah, I just want to share, we've been using ketamine on the aircraft now. Our providers have been for a number of years, and it's been very well received, and it's one of our favorite go-tos now over often fentanyl or morphine for some of the purposes, including analgesia. We also use it for bronchodilation, for RSI and induction, and for sedation. So storage is not an issue for us, and just off the top of my head, I'd have to double check. I think we pay about $12 per vial for the ketamine.
Okay.
And I just
Thank
logged
you.
on to Boundaries. I just logged on to Boundaries website, and this is before any discounts. They're charging $212 for 10 vials. So that's about right.
That's $22 a vial. I'm gonna reach out to Chomp and see what their pricing is. Usually it's a little better, but I support that, Eric, as well. Anything that can be applied to the system as a whole, and whether it's mandated or an optional for an agency, that might alleviate some of the financial pressures put on certain agencies. But again, I think having more options is, especially because of its added usage outside of what we already use our analgesics for, potentially has a greater opportunity to benefit the whole system. So.
Okay, thank you, Dave.
Chief Uelling? Dr.
Yes.
Stubblefield has a question.
Not so much a question.
Absolutely.
Say a couple of comments. I heard what Laura was saying, and I heard Dr. Burley too. Ketamine, again, it's been around forever. No need to preach to the choir. One of the nice things, though, is that you don't get the respiratory depression, and as well as the fact that it is not much of a problem as far as hemodynamics. Actually, there's a lot of literature, though, about it being okay for old people as well as young. And one of the things, although I haven't looked at an article in the last few months, but germane to what we're talking about is that with ketamine on board or in use, you may actually need less opioids. So, I think the stepping stones, of course, is that the drug will be approved through the agency. And then, of course, it's a discussion with the stakeholders and the hospitals, having that buy-in too.
I'm raising my hand. Real quick for Dr. Stubblefield and Burley and any other docs that have an idea, what is the general dosing for ketamine? What's the administration typical for, an average 100-kilo person?
Well, basically it's a milligram per kilogram.
Okay.
Okay, and of course it can be given IM or IV. Usually when I'm doing a moderate sedation, I go at the 1 milligram dose, but if you look in the book, it'll say 2 to 4 milligrams, but I find that you can get the effect that you need really at a lower level. John, Dr. Burley, you might want to speak to that.
Yeah, so I think we're looking at dosing for two different things. The ketamine is used for moderate sedation, which is a different dose than the analgesic dose. Moderate sedation dose is generally, if you're administering it IV, 1 to 1.5 mg per kg, as Dr. Stubblefield mentioned. And then if you're giving an IM, the dose is higher. It's generally 2 to 3 milligrams per kilogram. For analgesia, it's a much lower dose. So the general dose is 0.3 milligrams per kilogram IV, and so that's kind of what we would be looking at primarily for administration by EMS. We're not looking to do moderate sedation in the field. That's something that even in the emergency department, you need to have everyone there. You need respiratory therapy. It's a much bigger deal. And so I wouldn't necessarily be supporting the use of ketamine for moderate sedation in the field. I don't think that's safe. But for analgesia at the lower dose, I think that's certainly a very reasonable agent.
Totally agree.
Eric, I'm happy to share our protocol as well with our dosing to yourself or to the agency if somebody would like to.
Thank you. And also I did, as I mentioned, reach out to some of the other medical directors on MDAC regarding this issue and spoke with the medical director down at Inland Counties, who was kind enough to send me their dosing protocols. And I'm in dialogue with a few other folks. So, certainly as we mentioned, there are folks that are doing this. If it seems like it's something that's financially feasible, we'd like to explore it. I don't want to make any promises, of course, but I'm in favor of looking into it.
Yeah, and I was just asking so we could kind of get pricing, because it looks like it comes in obvious different dosing packages. So just, what would we be loading up on the ambulance? What would be our minimum stock kind of stuff, and what those types of vials cost?
Okay, well, thank you very much, everyone, for your input, Dr. Burley and Dr. Stubblefield and Jeff Horner. This is exactly what I was hoping for, was just to start to get this discussion moving, and we can gather information and determine whether this is going to be a good fit for our system and for our providers. So let's keep this on the agenda. Jeff, if you wouldn't mind, and Dr. Burley, I'd love to see existing protocol, and we can see if that's something that we could modify for our uses here in Monterey County.
Yeah, happy to send it to you.
Any further discussion on the potential introduction of ketamine? All right, item F is kind of another open-ended discussion. Oh,
Chief, can I just ask a question? You had also mentioned the intent to discuss morphine versus fentanyl and minimum stock. Did you want to discuss that further here, or is that something that you'd like to discuss offline with the agency?
Well, I think we can address it here. Essentially, I think there's a little bit of confusion among providers that they're required to carry both morphine and fentanyl. And I guess I just wanted a clarification that it is an acceptable practice for agencies to carry just fentanyl. So yeah, that was the clarification I was looking for.
So I think, in looking over this, our pain management protocol gives the option of morphine or fentanyl, and so it's that's certainly at the discretion of the provider. There is in our minimum stock protocol, I believe that we do list both because we wanted to have both available depending on the clinical scenario and the preferences of the provider. Recognizing again that there are cost issues and there's a need for efficiency and not carrying agents that you're not using. I think that we'd be interested in visiting a modification to minimum stock for fire units that may have different needs and constraints, or just doing away with one of the agents entirely. I know that if we're bringing in ketamine, for example, do we need to carry morphine, or is fentanyl a better agent to be using in the field, and does that alleviate the need for morphine? Of course, you have situations in which patients may be allergic to one medication or the other, so then you have to kind of look at that. So I think it's an interesting issue that you raise, and we'd be interested in visiting that, but I guess I'm curious as to whether the other stakeholders have any specific comments or share the same concerns that you have.
Yeah, this is Scott with Salinas. Looking at the minimum stock, when we hit the morphine shortages, Dr. Stubblefield had opened up the alternatives or equivalents, and they were both listed as the equivalents inside the minimum stock. And I think last point in 2019, it's fentanyl or equivalent and morphine or equivalent, and they don't say the same thing in the minimum stock. And I think that adds to more confusion in the providers too. There was a period of time where we simply couldn't get morphine. And we found great success with fentanyl as, shorter onset time, shorter duration, less histamine effects, and looking at the best efficacy of patient care. So yeah, we'd definitely be interested in further discussions to make sure we have options that are equivalent in providing the best options for patient care.
I'd like to add, I've ever since the introduction of fentanyl in the system, which was primarily driven by the trauma center's desire to have a less duration of analgesia on trauma patients, we've kind of been in the crossroads of between morphine and fentanyl usage. And just for our specific area, I find that a lot of the quote trauma patients going to a trauma center, the hips, the elderly, they tend to do a little better with the morphine, only because of the length of effect, and also for the transference of care at the emergency department. Just my personal usage experience. Also, just FYI, Boundtree is quoting $7.60 a vial, and that's a 500 milligram vial. So that will get pretty much, per patient. So it's $75.95 for a box of 10 vials. So it's about $8 a dose or per patient.
Definitely better than what I found. Thanks, Dave.
Yeah, no problem. No, that's like you said, list versus, retail versus, already approved.
Yeah, Dave's a bargain hunter when it comes to medication.
Got my own show.
Although he did mention personal use.
No, I think that was Dr. Burley who said that.
Personal experience.
Yeah, personal experience. Yes, that's what it was.
Okay, well, it sounds to me like we are moving in the direction of a somewhat larger review of minimum stock and the benefits of both fentanyl and morphine, and then the potential introduction of a third medication, ketamine, into the system. So I think this is a great time. We're sort of doing a reset in other areas. I think this is a great time to have these conversations. And my suggestion is, let's continue with the plan to get some sample protocols. Dave, sounds like you got a good handle on price. And then we can have a discussion at our next meeting about whether or not we want to maintain inventory of both fentanyl and morphine, or allow providers to have an either or scenario.
I totally agree with you, Eric. And I strongly suggest the either or scenario. I always think, anytime we limit ourselves in, an item that can be affected by so many different factors, we find ourselves chasing our tails at the end, trying to make up for, a shortage, a medication shortage, or something like that. So having options is always available. And yeah, that's my 2 cents.
Agreed.
Hey, Eric, I got a question regarding the morphine by the first responders carrying it. Are
Sure.
first responders not carrying it right now? Because I have heard that from our crews. So our crews are walking in without their narcotics because they're assuming the ALS has the full complement and the minimum stock. So I think if that's occurring, then we can remind our folks that they need to come in with their full complements into the scene to avoid any patient care delay.
Yeah, great question, Tino. And speaking for regional, we are only carrying fentanyl. We are carrying fentanyl and Versed. We initially, as Scott mentioned, were impacted by the shortage of morphine, and then following some research and some conversations, decided to hold off on bringing morphine back into our controlled substances arsenal. So as of now, we just have the fentanyl and the Versed.
Okay. No, I think that's a good reminder for our crews because we do get complaints and concerns that there's delay in medication administration. They're waiting for AMR to get there, which is not a problem for us. I mean, we carry everything. We have to, or else we get hit pretty hard. So I'll definitely put something out to our crews to keep their complements ready to go and into the scene, so there's no delays.
Yeah, and the city of Salinas is the same with that too. We do lock our chemicals within our controlled substance box inside the medical box. Are you guys, yours are on the engine, right, Eric? Still?
Yeah.
You know, copy that. And then Tino, yours are also in the apparatus?
I believe we do have both. It all depends how we, because we're assuming, again, when we're running with you guys, we're assuming you guys have everything available. And again, I know Will has mentioned it occasionally, but we can start changing how we, what we come in with. That's not a problem. It's just knowing what to expect.
Gotcha. Yeah, I know for us, and I think regional's probably been the same. We've been maintaining the stock for probably the last 2 years. Would that be consistent, Eric?
Yes.
Yeah. So it's not anything new.
Okay. Yeah. No. It's just to get our folks on board so that we get less of those complaints and they're ready to go once they get there. So I think that's our goal, is just be more prepared and which we are, but I just want to make sure that we get it ahead of time before it's delayed.
Yeah, and Tino, Silas just texted me saying that they're only carrying fentanyl as well. So, and I don't know, I mean, taking that to the next level, if a first response ALS starts administration of fentanyl, I know we were always kind of cautious. We didn't want to cross over with morphine on a follow-up, but I mean, we can do it, correct, Dr. Burley? But it's just something that we want to try to avoid, or?
Yeah, I mean, and I just also want to point out that if for example, you're only carrying fentanyl into the scene as the first arriving ALS provider, the expectation would be that, even if you don't have morphine, for example, you're delivering analgesic care while waiting for the transporting ambulance. So I think one of the concerns, if I'm hearing it correctly, was that analgesics aren't being administered until the transporting ambulance arrives, and just want to make sure that we do have the capacity. The patient, I think, doesn't necessarily care whether they're getting morphine or fentanyl so much as that their pain is addressed, and so I want to make sure that we're managing patients appropriately with the arrival of the first responding ALS units as well.
Yes, and Dr. Burley, just to provide clarification for regional, every medic engine has the capacity to deliver fentanyl, and whether it's simultaneous arrival on scene or other issues, they're not withholding any treatment or any medication while waiting for the ambulance to arrive.
Okay. Well, no, thank you for that. I think sometimes we are delayed, obviously, because we're limited on resources at times, and we're definitely relying on the ALS responders to really start the initial treatment. That's key. So thank you.
And for Salinas, ours are in our drug box with us at the scene of every patient contact.
Okay.
So, hey, it's Roger from CAL FIRE. So just for information, we carry all three analgesics with us, and they come in on every call. They're in the med box under double lock and key, and they come in on every call. So if you're having any issues with any of the crews on the peninsula, let me know. For whatever reason they're not giving them or waiting for the ambulance, that's an issue that I can address internally. Because they are there and available. They're in the med box on every call.
Yeah, no, CAL FIRE's been no issues with CAL FIRE. They've been solid. So thank you.
Okay, thank you everybody for your input, and let's go ahead and push this on to next month for further discussion. And then Tina, while I've got you, I was going to ask for your input on this next item, the low availability notification. And this is really, I guess, wanting to understand from a system perspective, if there's anything that we can do together as a system to communicate more effectively when the system status gets low. We found ourselves, we meaning regional, have found ourselves in the situation a couple of times where crews may be out training, they may be in the engine on a non-emergency detail, and the next thing they know, they're being requested to hurry back to the station for a mutual aid ambulance response or something of that nature. And what I'm wondering is there a mechanism where we can get a little bit of a heads up that system status is low, or is it just so dynamic that this would be occurring half a dozen times a day?
Exactly. It's very dynamic. It would be happening fairly frequently. If for the first 5 minutes that are going by, we might be low, but within the next 10, we're back up because we have units clearing the hospitals, units returning from out of county, units coming into service. So it's a roller coaster at times. You know, the demand pattern during the day changes, the movement of people changes. So we're always trying to get ahead of that. So I think when we know that there's going to be a prolonged delay because of an incident, then I think notification for all the first responders is key and important. But we definitely are pushing our crews hard to the point where they are, finding other ways to slow down their work. But it's because there's a high demand of calls, not just 911, but interfacilities. We're also doing non-emergencies.
Sure.
And if we have other demands in the system that we have to reach to make compliance. And that's been the big struggle is staffing at times because of call outs. People get sick with COVID. But I do think that once dispatch is aware of an extended prolong, I think notification should be happening. They do alert us, at least through the CAD paging system, that the system is at low levels. And we immediately start moving our folks in the direction of starting to clear them from the hospital a lot quicker. And, we're doing all kinds of things in the back end that I don't think a lot of people see. It's hard to say. I mean, do we call you guys out at level 3, at level 1? Level 1, we have Big Sur coming up, or at level 3, they're coming up. So now we're leaving that whole area uncovered. So it's a it's a moving target. So you guys let me know what you guys would like to see when we can try to implement something and try it out, see if it works.
Okay, well, I have noticed, I think it's great when the big unit comes up on county fire and they let Firecom know they're moving up to the peninsula. In our mind, that's kind of a trigger that levels are low and possibly be prepared for a response or a move up.
Yeah, and again, it could change within that 15-20 minutes. We have 2 units just came available and somebody just went in service, and now we're at level 6, and then we're back to 8, and then 2 minutes later the prison has a riot. Now we're back to 2 again. So it keeps moving throughout the day. So it's always a moving target.
Okay, good.
I'd just like to add to that, and I think Carmel's ambulance is closely aligned with the impacts of AMR's delivery, and I think you guys are doing a great job notifying us. We do move ups to help out the system, and those have decreased over the last several months, but yet the mutual aid calls have happened because they come down right on top of each other. And I know your dispatchers are quick to request us when they need us. So I think you guys do a good job in like Tino's saying, listening to the EMS side of the world and the fire side and the peninsula, responses, it changes so quickly. And, now that COVID's, simmering down and we're starting to get an influx, of tourism back on the peninsula, we're going to start seeing even greater challenges arising with, people who aren't flying, but now they're really coming down to visit and hang out. So I think you guys are doing a good job. And if there's anything we can do to improve, certainly look forward to it. But
Yeah, one thing to add is that once we start seeing ambulance stacking at the hospitals greater than 30 minutes, we start sending a supervisor. We notify the EMS agents, or at least send a page out. The BLS implementation has been helping, but again, it's hit and miss, because if they're pulled out for an out-of-county transfer, they're no longer available for a resource locally to do a BLS transfer. So, I think if we're seeing a low availability notification to the providers, I think, if we're can predict that within the next 30, 40 minutes, we're not going to have a greater number of, level 3 or greater, then I think that's appropriate to start notifying all the ALS providers in our area. There's going to be some delays. So I think this is a good idea. I don't think we should ignore this, because I think you guys knowing where we're at, it might be very beneficial for your treatment at scene.
Also adding on to that, I think knowing, like, let's say you have a known, sick out associated with the, illness, or you're down rigs. I think that's probably one of the biggest indicators of how the system's going to go. Because then, for instance, in Carmel, we listen to all the peninsula calls, so we get a good idea. Like, oh, Seaside just busted a couple of calls. Monterey's got a couple of calls, and that Carmel's going to be pretty much next in the queue. So when we know that there's, like, unfortunately uncontrolled circumstances, whether rigs are on transfers or you just have to shut down units, I think that's always helpful, because then you can kind of keep your ear to the grindstone, like, hey, what's going on here? But for the most part, I think the system's been working pretty smoothly. So
you guys have been a great help, as well as regional. Then, of course, our AMR Santa Cruz and San Benito that will jump in from the North County area. They've been a great help as well. So, I mean, and then South County area, they've been great as well with Cambria Ambulance and San Luis Obispo. So having those folks involved has helped tremendously in maintaining the integrity of the core of our units as well. So, but it's hard, especially when Chomp wants to take a patient all the way to, San Diego, then, we're stuck with that. So that happens. We just did a Ocean View transport last week. So there's a ALS unit out for 18 hours. So there you go.
I don't miss those days.
Tino, thank you very much for the insight. All of us have been in the system for a long time, but I still learn every day some of the finer details. So I really appreciate that. And thank you very much for providing some information about how AMR handles those fluctuations.
You bet. Thank you.
Any other questions or comments on the subject of availability notification?
Just have an observation. EMCC had a very detailed presentation with the EMD. As the EMD protocols rolled through the ops committee here, maybe it's in our best interest to have a briefing of how those EMDs are working within our committee also, because I think these are great questions about how the EMS operations intertwine, and how are we doing responding? Most of us are at all three meetings during the day and hear the same reports. But I think might be helpful if we had a smaller version of a snapshot of where we're at, so that we could actually have a feel for how the policies and programs that we ran through our committee to approve, how they're doing.
Mm-hmm. Yeah, I support that, Scott. That would involve Director Rios, are you still on?
Yes, we're here. So as
Just
far-
wondering if we would be able to,
As far as providing a.
yeah, if we were, to-
Oh, I'm sorry.
I'm sorry, go ahead.
Go ahead.
I was just going to ask if we could possibly borrow Kimberly to incorporate some sort of more streamlined version of that report to the EMS Operations Subcommittee.
Yeah, if it's something that this committee would like to see as a standing agenda item, we could do that.
I support that.
Yeah, I would support that as well. Why don't we agendize that for the next meeting? In addition to the discussion we had about controlled substances, why don't we agendize a presentation on bringing some sort of modified version of the call analysis into the EMS Operations Subcommittee, and we can take a vote at the next meeting.
Do we have to vote on that, or we need a motion, or we're good?
No, there's no need for a motion for that.
Okay.
Motion for what Eric said.
Yep. Second.
Okay, we have a motion and a second. All those in favor?
Aye.
Chief?
Aye.
Aye.
Tino?
Aye.
Olivia?
Aye, sorry about that.
It's okay. And Chief Nieto?
Aye again.
Okay, very good. Thank you.
Just point of order, asking for items to be added to the agenda does not require a motion or a vote. You can, members of the committee can request for items to be added to the agenda without a vote.
Okay, okay. So in other words, that was overkill.
We know there's consensus.
Yes. Well done.
Okay. Okay, thank you.
Well, good. That falls right into my next item for good of the order.
Okay, unless there's any other comments or questions for the low notification, then let's move straight in to go to the order. And it sounds like Jednick's ready to go.
So I know I've mentioned this over the last several years, and I think it's becoming more commonplace. And the subject is dispatch to unknown medical alarm responses. And what we don't have to get deep in the weeds today, but what I'm finding, and I'm sure Tino can back me up and a lot of other stakeholders here, is we're getting complete false alarms without any human interaction as the initiating requests. So basically, an alarm company calls up, says we've got an alarm at this place, and no one's answering the call. So we're rushing out to these places where there's no known emergency besides a potential pendant activation or some GPS watch from somebody that's visiting from out of the area. And we're sending 50,000 pounds of rolling stock, with lights and sirens. And I'm just curious what the efficacy of that is for a system that may be better off just responding, but not responding with lights and sirens. So pretty much downgrading. I know Jared Bagwell and I had spoke about this before the pandemic, and It's in one of the cards. I know it's in one of the cards, and he was looking at it, and I'm not sure if it ever materialized from that, but I would like to have this committee, I think it's the best committee for it, to look at possibly reviewing those types of run calls and seeing, one, using Kimberly's expertise, you know, what quantity of those calls actually turn into a real call and versus, you know, life and death call, or however that works, and bring it back to the committee to talk about and look at possibly modifying our responses to basically just unknown calls. So.
Well, we can definitely do some work and see what we can bring to the committee by the May meeting.
Perfect. Thank you.
Okay, anything else, Dave?
No, I'm good. Thank you very much.
All right, let's just move on down the line. Olivia, any go to the order items?
I don't have anything. Thank you.
Okay, Tino?
Hi, Eric. I do. I just want to remind folks, next month, April 11th through the 17th is dispatch week. So we will be providing stuff for our dispatchers and the county folks as well. So just a reminder to put on your calendars for to recognize our 911 dispatchers and our AMR dispatchers and Carmel dispatch as well.
Thank you.
Thank you, Tino, for that.
The dates one more time, Tino, April 11th.
I believe it's April the 11th through the 17th.
Yes.
Okay.
Yeah.
Okay, thank you. Jeff Horner.
I've emailed you, Eric, and Dr. Burley our protocol for the ketamine, so you should have that in your inbox. And I have nothing else for the deputy order. Thank you.
Okay, thank you. Laura Wallen.
No, sorry, got nothing.
Okay. Scott Houchin.
I don't know if it's good in the order, but with AMR's dispatch being relocated as COVID is changing, is there a plan to bring them back into county communications building, or is this going to be a continued residency over there?
I think right now it's going to continue as far as I'm aware. I know we need to talk to AMR, and but I believe things have been working out really well for AMR, and for us, I think that's the information I have. I don't know if you have anything to add, Tino.
No, so far so good. Everything's been working well for us. Occasional some issues that pop up, but they're corrected immediately. Again, we are available at Schillings or back at Natividad. So wherever you guys, wherever, you know, again, because of COVID, we had to just to make it safer for everyone. So everything's working out great so far. So.
Yeah. Is there a concern? Anything that we need to explore?
No, I don't think it's a concern. It's just when things change, we're creatures of habit and kind of anticipating if they're going to change back or if this is a situation that's working out well. It's all good. And for the good order, I wanted to thank Laura for all her hard work and dedication. This is a tough job, and we appreciate the heart and soul you put into it, and wish you well.
Thank you.
Scott stole my thunder. Thank you, Laura, very much for everything, and good luck in your future endeavors.
Thank you.
Thank you, Laura.
Chief Nieto.
Nope, I don't have anything, but it's been a long day, so thank you guys.
Okay, and any closing comments from Dr. Burley or Director Rios?
I know that by now everybody is aware that Laura has chosen to leave the EMS agency. I think her last day is May 16. We wish her well. We recognize all the work that she's done and her contributions to the EMS system. Just to make sure that everybody knows that we are in the process of implementing a transition plan. There should be an email coming out of the agency within the next week with our plan. But in the meantime, Deborah Hopgood, one of our new EMS analysts, will be the contact person for the program areas that Laura has been responsible for. But so we'll be in communication shortly with a plan.
Okay, thank you. Dr. Burley?
No, just to echo what Teresa said, Laura, we wish you all the best. And personally, it's been quite an interesting and enjoyable ride working with you during the time that I've been here. I know you've been here for a lot longer, but very, very much enjoyed it, and wish you all the best in the days ahead.
Thank you.
Okay, thank you, everyone, panelists and attendees. Unless there's any further announcements, we'll move into our notification of our next meeting, which is scheduled for Wednesday, May 12th, either in the Cinnamon Room or via Zoom. Thank you all for attending. I think we are moving in a positive direction in several areas. I appreciate all of your contributions. And Laura, best of luck going forward, and we will miss you. And with that, the meeting is adjourned.
Thank you, guys.
Thank you. Bye.
Bye, everybody.
Bye.